We stopped at type 1 hypersensitivity, and here's the next thing to discuss is type 2. Since we are in the micro, not AP class, we're going to use transfusion reaction as an example. So type 2 hypersensitivity refers to the immunological reaction mediated by the immunoglobulin G. And the good example of it would be a transfusion reaction. We have how many cell types? Oh, cell types. How many blood types? Well, actually, we have about 52, but when we transfuse the blood, we focus on those 4. Okay. So which types do we have? O, A, B, A, B. So those letters A, B, what do they refer to? The antigen on the surface, right? So we have A. So we have nothing here, right? Nothing on the surface of this guy. Huh? Well, for our purposes, we can leave it empty, but we can put H. Here we have A, here we have B, and here we have AB. What else do we have in the blood in addition to the antigens that defines the blood group? Antibodies, right? So which antibodies do we have in each group? So group AB, does it have antibodies? No. The B group, does it have antibodies? Anti-A, anti-B, and O blood group has... Does that make sense? Okay. Now, what's going to happen if we will transfuse the group O into AB? Will they? Well, they will. Okay, Sean is right. They will. But will this reaction be life-threatening? Why? If we transfuse O to AB, the reaction is not going to be life-threatening. What do we transfuse mostly? Huh? Red blood cells, right? And O, red blood cells, do they have antigens on the surface? They do not. Are they going to react with antibodies in the blood of AB recipient? And what I'm saying is these cells, they're not going to react with these antibodies. Well, there are no antibodies, right? Sorry, I got a little confused end of the day. So yeah, there are no antibodies, so cells are not going to react. Does that make sense? Antibodies in the blood that we transfuse, are they going to react with the AB antigens on the recipient cell? When we transfuse blood, are there any anti-A or anti-B antibodies in it? There are, but very little. That's the point. So when you transfuse the red blood cells, the amount of antibodies that can accidentally get into the recipient blood is very low. Now, will they cause hemolysis? A little bit. That's why when people receive the blood transfusions over and over again, because of that small amount of hemolysis, the transfusions cause the kidney toxicity. Does that make sense? So based on that, what is the universal donor? O. What is the universal recipient? AB. Okay. We're getting there. We're getting there. So it's not the only antigen that can be found, right? There's a D antigen, which is often called a rhesus factor. Some people are rhesus positive. Some people are rhesus negative. Do we have the antibodies that, how to say, we have from the beginning against rhesus? No, we don't. Can we form antibodies against rhesus? Which blood group should we have to form antibodies against rhesus? We have to be rhesus negative to form antibodies against D antigen. Does that make sense? Why do we pay attention to it? We don't give. Okay, what's going to happen if? Huh? No. What I'm saying, we actually why do we pay attention to blood groups in the first place? It's going to cause hemolysis, and the person is going to be royally screwed, right? Now, say rhesus factor. What can happen if you transfuse rhesus positive blood, rhesus positive red blood cells, into the rhesus negative person? Anti-rhesus antibodies. So, what these anti-rhesus antibodies will react with? What do they recognize? Rhesus factor, right? They will recognize the antigen. They will cause hemolysis of red blood cells. Okay, and especially after the second and third and fourth transfusion. Does that make sense? So it creates a problem. So what is the universal donor then? O negative, right? And universal recipient, AB positive. Does that make sense? Rhesus conflict. What's the problem? Say again? Oh, no, I don't really know the stats, so you may know more than I do actually. Is it? Okay. You see, I'm asking about rhesus conflict between mother and the fetus. Okay. Well, they have to be formed first. So let's take a glance. So you have mother, and you have fetus. And mother, in case of rhesus conflict, has to be rhesus negative, and the fetus will be rhesus positive. So when they are in coexistence before the delivery, are there any antibodies involved? No. Why? Why mother doesn't produce antibodies to the antigen? Huh? She hasn't been exposed to it, but why she hasn't? The baby's like inside her. No. What I'm saying is, mother doesn't have any exposure during pregnancy, first pregnancy at all. Why? Why she's not exposed to baby's blood? Through which barrier? There you go, because they're separated by placenta, right? The mother's blood and baby's blood is separated by placenta. Okay, we're good? We're moving on. And then mother, at some point, gets exposed. What happens? No. When is she getting exposed? During birth. And then she produces anti-rhesus antibodies. So what? Okay, she has another kid. She's still rhesus negative. Kid is, well, if the kid's unlucky. Okay. And mother also has anti-rhesus antibodies. Can they cross placenta? Yes, it's IgG. So what they're going to do to kids, well, fetus, red blood cells? Huh? Yes, hemolyze them, and baby's going to be hypoxic, anemic. Well, not baby, it's going to be fetus, still fetus. Kidneys will start to shut down, and the whole transfusion will help, pretty much. Can we avoid this? How? What do they do, ROGAM antibodies? It's low dose of anti-D antigen, anti-D antibodies. Why does it help? Wait a minute, let's picture it. Okay, let's picture it. You're going to explain, and we're going to picture it. So, we have fetus red blood cell, which has D antigen. So, you inject ROGAM. What does it do? Binds to what? D antigen. So now we have this. How is it going to help mom?
She's not going to reduce her own D antigens because it's already taken care of.
Yes. So essentially, ROGAM masks D antigen and makes it hidden from exposure. Does that make sense? That's it. Does she have to get ROGAM every time she's pregnant?
Only if the baby is RH positive.
Yeah, but usually they don't risk. I mean, obviously, if you can test, then it can be picked. But usually they don't risk and just give ROGAM. Because if you try to get some baby's blood, you expose the fetus for the high risk of preterm delivery. Okay? Does that make sense? Type 3. Immune complexes. So this is the true autoimmune disease, and great example of it is lupus. In case of immune complexes, it's also IgG. Okay, your B cells start to produce antibodies against your own tissues, namely the antibodies against basement membrane. I want to remind you how our epithelium looks like. So these are epithelial cells, okay? And they're attached to the basement membrane, that black stuff on the bottom. Now when antibodies reach the basement membrane, what they're going to do? Oh, wait. What first antibodies? What they do when they encounter antigen? They bind to it. Can antibodies destroy anything? Destroyed, like directly? They can't. But what they do actually? What's the function of antibodies? Yes, so antibodies will tell neutrophils and macrophages to attack the immune complexes. So you have macrophages and neutrophils. And macrophages and neutrophils essentially will destroy the basement membrane. Does that make sense? If basement membrane is destroyed, what's going to happen to you? Epithelium is going to start falling apart. Where is epithelium? Skin, so you're going to have skin inflammation. Somewhere else? GI tract, yeah. It's connective. GI tract, yeah. There's going to be inflammatory bowel. Respiratory, yes. There will be problems with breathing. For some reason, lupus mostly affects joints, kidneys, and blood vessels. So it affects simple squamous and simple cuboidal epithelium. Okay. Now, in blood vessels, there's going to be inflammation of endothelium, which leads to the frequent thrombosis. In kidneys, it's going to be inflammation of the glomeruli and glomerulonephritis and kidney disease. And in joints, it's going to be synovial membrane that will become inflamed, causing arthritis pain and arthritic inflammation. Okay, so it comes from B cells, antibodies attacking your own tissues. Does that make sense? Finally, type 4. Type 4 is often called a delayed response. It's mediated by T cells. And it can be the allergic response. Well, let's think about allergic response. Poison ivy, yeah, we can talk poison ivy. We can talk tuberculin test. Let's do tuberculin test because it's more relevant. Okay, and we can do poison ivy as well. Okay, so tuberculin test, what does it do? If you have, it turns out that your response to Mycobacterium tuberculosis depends not so much on the antibodies, but mostly on the T cells, yes. So it checks for the presence of T cells. And among T cells, we know two populations. We just learned it today. CD4 and CD8. And one of these populations is helper, and another one is killer. Okay, so now let's see what happens when you get exposed to the tuberculin, the antigen of Mycobacterium tuberculosis. Let's say when you are sick, when you're infected and you have active tuberculosis. So you have an antigen, okay, and antigen is being presented, and then it leads to the activation of T cells, right? What's important, you will have a set of memory T cells. Does that make sense? So how is the tuberculin test done? You get the injection. Where? Huh? So what? Before where? No. I'm not talking about geographical location. Intramuscular, intravenous, subcutaneous. It's called into the skin, intradermal. Is there a reason? What's under your skin actually? What's under the dermis? Fat. Is there any point shooting antigen into the fat? Not so much. It's going to take a long time for it to get in the bloodstream, and you don't want it to get in the bloodstream. Instead, you get injected into the skin. What's in the skin? Immune cells. I mean, I'm asking, which immune cells? Huh? They will get there, but they're not sitting there. Langerhans cells. In the epidermis, there are Langerhans cells. That's a type of dendritic cells, okay? So we have tuberculin injection. What? Oh, crap. Injection. So Langerhans cells present antigen. And remember, you have memory cells. They will become killer cells. They will become helper cells. So T killers and macrophages will rush towards the site of injection. Does that make sense? Okay? They will extravasate, yeah, and they will rush to the site of injection and they will start to destroy your tissues. So we'll get an inflammation, okay, because that's going to be inflammatory response and adaptive response. So what you're going to get, a bump. And the bigger the bump, the more cells you have, the more likely you have an active TB. There's a little bit of a problem. If you've been vaccinated, like I was, you will get the reaction, although you're negative. I was like, and it depends on how effective the vaccination was. So mine wasn't extremely effective. So I passed the TB test every time. Other people that I know were not so lucky. One of my colleagues who is from Ethiopia, pretty much the entire world vaccinates against TB. US doesn't. Vaccine is not really effective. But anyway, he's got his TB test and it came out positive. So chest X-ray is often not reliable because it may not be like a fulminant tuberculosis. So he was prescribed a set of antibiotics. Well, he wasn't an idiot, so he started to flush them down the toilet. Well, people who prescribed antibiotics were also not idiots, so they started to test his urine. So they won. He had to finish the course of antibiotics, although he didn't have TB. The words about vaccination didn't convince the administration of the hospital. And then after the proper course, he was cleared to work with mice. Okay. Now, poison ivy works slightly different. Well, it is similar idea. It works slightly different. In poison ivy, the primary exposure is when you touch the leaf, okay? And the chemicals from poison ivy, they usually stick to your proteins, like haptines, okay? And your immune system starts to respond to them, starts to recognize them, producing by production of T cells. First exposure to poison ivy is usually unnoticed. But then when you get the second exposure, that's when T cells get activated, macrophages get activated, and they migrate to the site where the antigen is and will start to disrupt your tissue. That's why you get the symptoms. Does that make sense? And last thing on agenda is transplantations. There are 4 types of the transplants. First is from self. What? From self, and this is called autograft. Well, I was hoping for auto. Okay. Then if you have an identical twin, you can share organs. That is called isograft. But that is a rare instance, and most transplants come from different person. This is called allograft. Sometimes you get structures from animals. And this is called xenograft. Xeno means alien. But that happened to me before. Huh?
It's happened to everyone, I think.
Yeah?
I went to a nutrition class and walked into a dentist class one time.
It's not the worst. The restroom is the worst.
The restroom, what?
Especially when you're really like occupied with your own thoughts and you walk in and your first thought, why there are no urinals? They should be here. Oh crap. Now, describe me the clinical situation when we can get a transplant from self. Mostly, I mean, organs obviously not an issue. Skin graft, yes. However, we now technically, we now have techniques, we now have methods to treat leukemia, for instance, when T cells are taken from person, okay, modified in some way, and then placed back in a host. So my T cells, or I don't know, whatever, white blood cells are taken from me, there's certain modification, and they put it back. You may have seen the title of the title in the news. I don't remember how long ago was it, maybe a couple of years ago. Doctors cured the girl's leukemia by infecting her with HIV. No. They took HIV, got it out, removed most of the genes, put whatever they needed into the virus, made it a vector. Then took the girl's white blood cells, especially CD4 cells, infected them with that modified HIV, which cannot cause AIDS, and placed the cells back in the blood. The girl had B-cell leukemia. These CD4 cells started to attack leukemic B cells and destroy them. And she was in complete remission since then. It's a wonderful method. It's really a great method. The only problem is it costs a fortune, of course. Identical twin, well, identical twin. If you have an identical twin, you're lucky. Or he's lucky. Or she's lucky. Depends, you know. Who's gonna come first? Allograft. When we refer to different person, who is different person? Somebody that is not identical twin. A mother, father, brother, sister, they all sources for allografts if they're not genetically identical to you. Does that make sense? Often the person who is not related to you may be a closer match than your relative. The match is based on a number of antigens. Pretty much the closest is the proximity of molecules of major histocompatibility complex. Does that make sense? So they actually can determine based on MHC what is your best match. And xenograft is not frequent. People try to transplant organs from other animals for a long time. Pigs and monkeys are the examples, but it never went well for the recipient. I'm not talking about a monkey or a pig. But in some cases, we use transplants for heart valves. There are actually, here's an idea. I don't know how far they went, the scientists. They wanted to do a transgenic pig. So they take a pig and make it express human major histocompatibility complex. Does that make sense? So humanized pig, immunologically humanized. And then if you can make it a stable line, you can just start producing pigs that you can take hearts out and put in somebody else's chest. Okay.
Is that the only part? Is the MHC that would like be important when it comes to the transplant?
We'll get, but it will be it's most important. Okay. Because that what defines self-foreign. So what are the problems with the transplantation? What is the major problem that arises after the transplantation? Rejection. What is the mechanism? So transplant has MHC, right? And it presents the antigen, right? The antigen presenting the T cells. Or, for that matter, dendritic cells, or any other antigen presenting cells. They're going to acquire that antigen. Does that make sense? And they're going to present it to the T cells. And eventually you're going to get a population of recipient T cells that will recognize the MHC class 1 of the donor. And they will start to destroy the donor tissue or cause inflammation or whatever. How do we fight rejection? Mostly.
So there's some kind of drug thing.
We suppress what? Immune system of the recipient. Suppress immune system of the recipient, but if we suppress immune system of the recipient, we put recipient at the higher risk of what? Infection. Yes, infection. That is always a problem whether it's a solid organ transplant or it's the transplantation of bone marrow. Speaking of transplantation of bone marrow, let's see if you have someone who has a blood cancer, blood malignancy, okay, leukemia. So what is the regular treatment? Radiation first. So what do you radiate the person? What do you radiate the person for? Why? Why? Gamma rays, huh? Well, you radiate, like people with leukemia. When they're exposed to radiation, what's the purpose of the procedure? First. It's not treatment, actually. It's a preparation for a treatment. What do they kill? Huh? They kill bone marrow. Right? So they just completely destroy bone marrow. And what do they do next? Huh? Wait a minute. Wait a minute. Well, chemo, okay. The purpose of chemo is again to destroy the bone marrow. Because it produces malignant cells. But if you destroy the bone marrow, can you just leave it like that's a person without bone marrow forever? You have to give the person a new bone marrow, right? So we're talking about bone marrow transplant. Okay? We're good? Now this is and bone marrow will start to produce what? Blood cells, red blood cells, right? Platelets, white blood cells. One of those white blood cells will be T cell. Okay? Here's T cell receptor. And it encounters the host tissue. And it looks foreign. And what this donor T cell is going to do? destroy the tissue. This is called graft versus host disease, GVHD. So the mechanism is more complex. There is a present. So you transfer some of the mature white blood cells when you transfer bone marrow, and in fact, it's not just they just throw themselves into the bloodstream and start to wreak havoc. The antigen has to be presented to them. It can be presented by dendritic cell of a transplant, produced by transplant, or it can be presented by dendritic cell of the recipient, okay? And it can happen. So there are two ways of presentation. They can get activated. The problem is you don't need much. You essentially need the activation of pretty much 1-2 T cells, so they will start to proliferate. Does that make sense? And then eventually, so GVHD in patients doesn't happen overnight. If you do not immunosuppress, it still will take probably weeks for the disease to occur. How do you treat? How do you treat abnormal response by T cells? What do you suppress? T cells. You give immunosuppressants. Does that make sense? So now my personal hope is for induced pluripotent stem cells. When they take your own cells, like fibroblasts, and program them, they come back to the stage of embryonic development, and then you can guide them to become whatever you want. So I really hope it's going to happen, and we're going to have, we can grow like bones and muscles and organs. You can take the cells from the patient, make them hematopoietic stem cells, and put them back into the bone marrow, okay, and they will do that. But I don't know if it's going to happen in my watch. Okay, does that make sense? Regarding transplants, know there's 4 different types. Know what the rejection is. Know what the graft versus host disease is. A few words about transplantation and associated abnormalities. If you suppress a patient and the patient has a latent infection, what's going to happen to the latent infection? It will become acute. Does that make sense? So if you have a patient who has Epstein-Barr virus, and this patient receives the transplant and receives the immunosuppressive therapy, Epstein-Barr virus will reactivate. That makes sense so far? One of the major causes of rejections in the kidney transplant is the cytomegalovirus, which often resides in kidneys. I'm sorry. It was in my office. I didn't know that the sound is on. Okay, so the virus resides in kidneys. Okay, when you transplant the kidneys, you transplant the virus, right? The recipient, let's do it. So there's a recipient, okay, and this is the kidney, and it has CMV in it, and it's latent. So the CMV goes into the patient after immunosuppression. The kidney will start to churn out active CMV. Okay, it's going to have the acute CMV infection. Interestingly enough, it's not awfully heavy in terms of the symptoms, but CMV infects endothelial cells, in the blood vessels become obstructed. Well, they become inflamed. Reaction to inflammation is the growth of the blood vessel walls. Lumen of the blood vessel reduces. Blood flow to the newly transplanted kidney shuts down. The kidney dies. Well, becomes dysfunction. Okay, hypoxic, and it doesn't work, so they have to do something about it. Okay, I think I brought up the case of rabies in the transplanted organs. Well, the guy died in a car crash. His organs were taken, transplanted to a bunch of other people. The guy turned out to have rabies in the incubation period. So all those who received his organs died of rabies. It's a pretty sad story. Sometimes, though, the transplantation can provide the cure from the disease. Huh? Because rabies is fairly rare. No. That's the good question, and that's the problem. I can tell you. So we cannot respond proactively. We only respond reactively. For instance, one of the major routes of transmission for Chagas disease in the United States were blood transfusions. Until we figured out it's too much Chagas disease, let's start checking everyone for Chagas. Okay, so if you donate blood and they ask, did you ever have Chagas disease? If you had, you may say no, but your blood is going to be checked anyway. Okay, and that's a fairly easy test. Okay, so there are plenty of situations when this is the case. There was although one interesting case when a person who was HIV positive, also had a leukemia, and the person was irradiated, so bone marrow was completely destroyed. Absolutely, totally destroyed. And the person received a bone marrow transplant from a donor which had mutation, so-called CCR5 mutation. That mutation makes person's CD4 cells resistant to HIV. So they cured the guy from leukemia and from HIV. He was in complete remission in both instances since then. It's kind of an interesting case. Okay,